So I've talked a lot about how emotions, thinking, behavior, social interactions are key to understanding chronic pain. Let me talk just a little bit about cognitive behavioral therapy because it has become a standard feature of multidisciplinary pain clinics that want to use the biopsychosocial model to help patients suffering from pain. Cognitive behavioral therapy complements usual management of pain as directed by healthcare practitioners such as physicians, nurses, physical therapists, rehabilitation therapists, and the like, complements their approaches by focusing upon the psychological well-being of the individual. So while the therapy is usually tailored to the problems confronted by a particular patient, it typically has a number of stages, and let me rapidly outline them and then come back to them in particular. Usually there's an education stage in which we try to help people understand pain somewhat better. Usually we focus upon exercise and fitness training to try to counter the effects of deconditioning. Often there is skills training in coping strategies, cognitive and behavioral. There frequently will be some contingency management in which we try to engage people in more pleasant activities that are reinforcing of well behavior. Often we'll help patients set goals, limited goals, in the first instance to help them in small stages overcome the pain and pain-related disability. There frequently will be some cognitive therapy in which we try to help people think in different ways about themselves and their pain and their interactions with other people. And finally, we'll work on relapse prevention. We know that it's virtually inevitable that there will be bouts of serious pain, and we try to provide people with skills that they can use to overcome the pain themselves. So let me just run through these in just a little bit more detail. It could take many hours if I really got going, but I'll try to prevent that. So education on pain. Often people are overwhelmed by fears of pain that relate to misunderstandings and myths. So such factors as pain is inevitable when you get old. Well, what happens when you get old is the diseases kind of catch up on you, and the illnesses or the pain relates to the diseases, but those diseases and injuries, they're compatible, and there's no reason why people should continue to suffer from pain. Pain isn't an inevitable feature of aging. Similarly, there are many myths relating to the use of potent analgesics. People should not be discouraged from using potent analgesics. On the other hand, we need to be very careful about the potential for abuse of potent analgesics. So lots of education needs to be undertaken for people. Exercise and physical fitness, probably best done by people who have expertise in physiotherapy and rehabilitation, but getting rid of the deconditioning, building up people's capacities for engaging in physical activity, using those muscles and joints and limbs effectively again is exceedingly important. Skills training with respect to coping. Relaxation is probably something that everybody should learn, whether they're suffering from pain or not. It's a marvelous way of dealing with the stress and strain of daily life, but particularly effective in combating the stress and strain that goes with persistent pain. Activity pacing, so that goes with the deconditioning approaches. attention diversion so that people don't ruminate and become preoccupied with their persistent pain. Stress management approaches in general work well. Contingency management, well, try to set up one's life so that the more difficult kinds of things are followed by pleasant activities. We'll do surveys of the kinds of things that people like to do and try to make them contingent or a consequence of doing a little bit more work than they ordinarily would do, practicing some of these skills for coping with pain and the like. So that's an important part of our cognitive behavioral approach. Goal setting can be important. This is always highly individualized, in which we teach people to work on tiny baby steps in the interests of long-term mastery of persistent pain. Cognitive behavioral therapy gets quite technical. We use terms like cognitive restructuring or reframing one's thinking, trying to get people to focus on the more positive to avoid being preoccupied with their misery. Some of the assumptions about what people can do and won't do become the focus of cognitive restructuring. Finally, relapse prevention. Well, we try to work on the sequence of a lapse, a bout of pain, not being successful in managing the pain. If the lapses become too common, it becomes a relapse, and we try to teach people to recognize risk factors for relapse. Most of all, what we want to avoid is a total collapse, falling back into the sick role or being an invalid again. You can anticipate that these things will happen. We can teach people to anticipate these things will happen. And under those circumstances, they can begin to use the skills that they've learned to deal with them more effectively. That sums, in a nutshell, cognitive behavioral therapy, an important part of treatment at this stage of the game.